So good morning, everyone. So we're starting this session of Global Medical Physics Education Series, and our speaker for today is Dr. Travis Salzillo, and I'm going to give a short introduction to our speaker. He graduated summa cum laude from Tarleton State University in Texas in physics in 2014. He finished his PhD in medical physics in 2020 from MD Anderson. From his dissertation, he used hyperpolarized MRI to assess glioblastoma metabolism in mice. He then did a 2-year postdoc also at MD Anderson, working in MRI-guided radiation therapy. He's now the chief medical physics resident at MD Anderson. So today, Dr. Travis Salzillo will be giving us a talk on motion management in radiotherapy. Yeah, thank you, Dr. Travis, for this opportunity. You're welcome. You can start now.
Great. Thank you for the introduction as well as the opportunity to speak today. So this is a very broad topic, motion management radiotherapy. So over the next 40 or 50 minutes, I'll try to go through as much as I can with my experiences here at MD Anderson, as well as other techniques that I've seen elsewhere. So just as a brief, there we go. Just as a brief background on myself, just so you know who I am. I grew up in Texas, went to high school there in a small town called Georgetown. It's just north of Austin. And then in 2010, I moved to Stephenville, which is a very small city in Texas. There I went to college at Tarleton State University. I did math and physics for my undergrad, and I did computational physics for research, undergrad research while I was there. That was right on the precipice of high performance computing and GPU computing in the medical area and in the science area. Prior to that, they've been using it for high-end computer graphics and everything. And around that time, people started figuring out you could use it for computational purposes as well. So that was a really exciting time. While I was there, 2 summers, I did summer research at other institutions, one at A&M where I studied theoretical nuclear physics, specifically the formation of quark gluon plasma from high energy collisions. We simulated ones that they were doing, for example, in CERN. And then at the following summer, I went to Michigan State up north, and there I studied experimental condensed matter physics. And specifically, I worked with a ultra-fast electron microscope. In 2014, I graduated college. I moved to Houston, which is a lot bigger than Stephenville. I think the 3rd or 4th most populous city here in America. And here I studied medical physics, specifically, as we mentioned, using MRI to study metabolism of brain tumors, specifically glioblastoma. And then after graduating, I joined the advanced fellowship here at MD Anderson, which involved a 2-year postdoc and a 2-year residency. And so for my 2-year postdoc, I worked primarily with the MR-guided linear accelerator, the MR-Linac, that we have here at MD Anderson. So I give you this background just to kind of demonstrate the variety of different research topics I had over the years. And I actually did make the switch because during my PhD, I focused more on the imaging side of physics, diagnostic imaging, preclinical, that kind of thing. And even though I've now joined the radiation physics residency and ultimately, hopefully, the faculty department, I've hoped to find ways to leverage my experience in imaging that I got during my PhD in this field of radiation therapy. And so that's kind of why I wanted to talk about that today, because I have a bit of a unique perspective coming from both sides of medical physics. So today we'll talk about 4 main topics. Talk about the different types of motion encountered in radiation therapy, passive ways to try to minimize this amount of motion, alternative active ways, specifically through imaging to also minimize motion, and then the incorporation of biofeedback, which is basically having the patient participate in the motion management. So these are 5 primary ways that I have encountered motion in radiation therapy. There might be a couple more very niche categories. The main one that we try to minimize is just gross patient motion. So anything like twitching or involuntary movement, or just over time, as you're sitting on the table, as the patient's laying on the table, any type of movement that they might occur with their body, um, coughing, swallowing, things like this. Respiratory motion obviously is involuntary. We can control the rate at which we breathe and how much we breathe, but that's something that we'll have to deal with for thoracic and for abdominal tumors in treatments. Cardiac motion, fortunately, even though this is a very high frequency motion, it's several hundred beats per minute up to in some cases. The magnitude of the motion is quite small. So typically we don't have to worry too much about cardiac motion unless we're actually targeting the heart itself. And there are a few instances where that's done in radiation therapy, but very rarely. And on the whole, you typically don't have to worry too much about cardiac. Peristalsis is more of a slower frequency motion. That's the movement of gas, gas and waste through the intestines and through the stomach. And this actually is something that we do have to worry about, especially when we're treating GI tumors. Even though it is slow, it can affect the distribution of the organs both from fraction to fraction, or as well as within one fraction itself. That and this last aspect of motion, bladder filling, very similar thing, especially in GU patients when you're treating prostate, or you're treating kidney, or in GYN patients when you're looking at cervical cases. Bladder filling actually affects the distribution of the organs and the target in some cases. And so that's something that we also have to take into account when we're treating these tumors. So if we go back to the more basic forms of motion management, ICRU is one of our more fundamental documents that we follow. And in ICRU 62, they actually made the switch where they started incorporating motion into their margins. So some of you are familiar with how we classify different margins in radiation therapy. You have the gross tumor volume, which describes the tumor that you can actually see on imaging or palpate. You have a clinical target volume, the CTV, which encompasses microscopic disease that we can't see, but from a clinical experience, we know that there's a high probability that it is there. And traditionally, that's all we worried about. However, over time, we recognize that due to setup errors as well as motion within the body or within the patient itself, these margins weren't sufficient for completely covering the target from fraction to fraction. And so this group, they propose two additional margins, the setup margin and the ITV, or the internal tumor margin, internal target motion. And so the combination of these two margins give us today what we know as the PTV. And that's something that's very common across all areas of radiotherapy, is that all tumor and radiation plans have now a PTV. There are a few that don't if you're doing very high SBRT type of treatments, but most of them have a margin around them that do account for this internal motion as well as this setup error. So there's a few task groups that go into this. TG 101 talks about SBRT treatments, and that's where setup margins and setup errors become very important. And then APM's TG 76 talks about actually managing motion, especially respiratory motion in radiation therapy. And that deals more with defining your ITV, your internal target volume. So these sources of error give rise to both, can be classified into both either random errors or systematic errors. Random errors are ones that you can't predict, but they do occur throughout a treatment, through refraction of treatment. And typically that's small setup uncertainties or organ motion itself. So a lot of the motion that we get, and a lot of the reason we have margins is because of this random error that occurs with our targeting. Systematic error can be more associated with improper contouring, consistent patient misalignment every day, a bad breath hold, for example. We'll talk about that later. We don't worry too much about these in terms of motion management, because motion falls more into the random category. But it is important to know that the systematic errors are very important in this treatment. And as a result, sometimes you'll get from random motion this blurring of your dosimetry. So if you had a spherical target here, and you induced random motion into it, you start to see this dose distribution start to smear across the area you're trying to treat. And so your very conformal targets now become a little widened as a result of that. So how do we mitigate some of these errors, and how do we account for this motion that can cause these errors? Well, the most basic one, as I kind of alluded to, just increase the margins, right? If you increase your margins to encompass your ITV and your setup margins, then you take this dosimetric spread that we just talked about, and we ensure that we still distribute the target amount of dose, prescription dose, to the area we're trying to treat. There's several margin formulas that have been described in the literature over the past years, actually over the past decades, I should say. This one, the Van Herk formula, is probably one of the more common ones that's taken. So in this table that I showed, this was a really good study where they split up systematic errors and random errors from different sources, so organ motion or setup errors, and this was, I believe, in prostate patients, prostate treatments. And as a result, they could derive this formula for how big they should make their margins to ensure that 95% of their patient population still received the adequate dose to treat their tumors. And so there's all sorts of different margins here, or margin formulas that you could use, dozens, I would say, but this is the most common one. The only problem is once we start increasing margins, we also start increasing the amount of normal tissue we're radiating. So the bigger your margins get, the more sure you are that you're hitting your target, but there's now an increasing likelihood that you're going to experience radiation toxicities because of all the extra normal tissue that you're irradiating. So this is a simple way to help address motion, but it's not necessarily the best or the only one that we want to focus on. So to reduce patient motion, once you lay on the table, and to reduce setup uncertainty, we have different types of immobilization devices. So different vendors have different solutions. For example, Electa has a stereotactic body frame. This also includes some abdominal compression. That's a very common method of immobilization in GI tumors when you're trying to compress the amount of motion. We have these vacuum lock bags. They're similar to bean bags, basically. And you evacuate the air and mold it to the patient. And once the patient gets up, you now have like a hard shell or a cradle that the patient can lay in every day. And this provides a very consistent setup from fraction to fraction. You can have larger ones, and we typically at our clinic we have these large blue ones when we're doing SBRT, so very high, high dose per fraction treatments where we need to be very precise and conformal. But we also have these smaller vac blocks, and these are more traditional treatments. So if you're giving 30 fractions, 25 fractions, 40 fractions, your dose per fraction is not going to be as large, and so you can actually get away with using some of these smaller backlogs, which still provide an immense amount of support and precision when you're setting up the patient. But they're not as expensive, and they're not as cumbersome and large, so they're much easier to store when in between fractions, for example. We've also incorporated for a very long time now thermoplastic masks for head and neck treatment, as well as some CNS treatments. So these come as flexible meshes out of the box, but once you dip them in hot water, they soften, and they allow you to mold them to the patient's head and neck area. When you do this, after you let it cool, just like the vac blocks, you now have a very hardened shell. And we've had a couple studies at our institution that demonstrate that there is a significant clinical benefit for using these masks. You'll also see here the patient has a bite block kind of in their mouth, and this helps reproduce the jaw and the mandible from fraction to fraction. It also depresses the tongue, so it gets it out of the way, so there's no incidental tongue motion, and makes it a little more difficult to swallow. So swallowing motion during the treatment's not as big of an issue. We also have these infrared reflectors that we put on the mask. These are used for ExactTrack. Nowadays, you don't have to use these. ExactTrack has done a really good job of imaging like features on the patient themselves, or using surface guidance. We'll talk about that a little later. But this is kind of the setup that we've traditionally used at our clinic. We also have what's called a clarity cushion underneath the shoulders, and that kind of serves a similar purpose as a vac box. It gives the patient a consistent place to lay their shoulders. And this is all very important when you're doing very conformal treatments in the head and neck region, especially with all of the very sensitive organs around, like the parotid glands, the eyes, the swallowing muscles, the mandible itself. So this has been a really useful and very consistent part of our treatment for these types of tumors. Okay, so that's how you can help produce, gross patient movement, incidental movement that could completely throw off your targeting profraction. Now let's talk about peristaltic motion and bladder filling. So this is a figure that I got from a paper here that talks about looking at the effects of peristalsis. So peristalsis again is the movement of gas and waste throughout your intestines, and this is on a slower timeline during compared to respiratory motion or cardiac motion, but it does in fact affect your targeting. You can see here on the left, we have the duodenum, you have the head of the pancreas, and you have the stomach here. And as the stomach fills, either with gas or with fluid or with food, you can see the effect it has on the pancreas. So if you're targeting the pancreas and you don't account for this peristaltic motion, either before treatment or during treatment, you could completely miss your target. Another example, a little lower down in the intestinal tract, is the rectum. We often have an issue with either rectal filling due to waste or gas itself. And it's a little tougher to see on this figure, but if you pay attention to the bottom, you can see this black area is a rectum, and there are significant changes in your prostate, both the shape of the prostate and the location of the prostate, depending on the amount of gas that you have in the rectum. So that poses a significant problem whenever you're trying to target areas in the GU site, so prostate, cervix, things like this. So what do we do? The easiest answer is we tell the patients do not eat or drink for 3 hours prior to your treatment. And the goal for this is to reduce any amount of stomach filling, as well as to reduce any motion or peristaltic motion throughout the intestinal tract, so that every day you have a very reproducible setup and your setup doesn't change within the fraction itself. Other options that I've seen here at MD Anderson at our clinic, especially for prostate treatment, we'll often ask the patients, or we'll implement an enema. We'll give the patients an enema before they get on the table. That helps clear out any potential waste that is in their rectal area, and so that gives a more reproducible setup. There's something called the Nacho rule, which I thought was really interesting that I learned about. One of our GI doctors noticed that if you gave patients, if you told them to eat nachos or something that's high in fat the night before their treatments, it would empty their gallbladder, because the bile would basically the physiological effects of digesting the high fat diets empties your gallbladder every day. So the next time they come into treatment, that's one less thing you have to worry about. One less thing that can affect the setup of the target, the patient, every day. So I thought that was really interesting. He called that the nacho rule. So while they're getting treatment, eat as many nachos as you can for dinner the night before. And then lastly, cone beam CT verification. So that's the easiest way to ensure that there's no motion, both between fractions, so when you set up the patient initially, as well as if you're administering a long treatment, to ensure nothing has changed. So for example, we have SBRT cases that can sometimes take up to 15 minutes of treatment. And I'll talk about this on the next slide, but for bladder especially, but including rectal filling or peristalsis, this could be a long enough time period where you do see an effect. And so especially if you have these long SBRT treatments, having a cone beam CT halfway between, if you can manage it, does wonders to ensure that you're still going to be treating in the same area that you think you're going to be treating in. So again, as I alluded to, bladder filling is another big one. So bladder filling occurs on a more rapid time frame than peristaltic motion. We'll notice that over a period of 30 minutes, you can grow your bladder volume, from a couple 100 cc's or 50 cc's all the way up to 400 or 500 cc's, depending on how much water you drink. And you can see here in this figure, if we look at the bladder here, how much of an effect it has, um, on your intestines here, which are really important if you're trying to avoid them during your treatments, as well as the anatomy immediately posterior to it. It has a very large effect. And so when you have these treatment plans that you've created during sim for a specific prostate or specific bladder filling, you have to make sure you reproduce it every time you come to treat. And so the biggest thing we ask people to do here at MD Anderson is you have a comfortably full bladder before you actually get on the table. So for a lot of prostate patients, the physicians will notate we need a bladder filling of X, and usually that's the amount of bladder filling they had during simulation. And the way they can check this is to use an ultrasound. So when the patient arrives, before they arrive on or get on the table for the treatment, we give them an ultrasound, and we can easily see the relative amount of bladder volume that they have. And if that number doesn't match within 10% or so, we have the patient either go to the bathroom and release a little bit, or we have them drink more water and wait so that the bladder gets to a very consistent size as it did during simulation. Again, for long treatments, for SBRT treatments, we also have to image, halfway through treatment sometimes, because on the order of minutes, you could see that the bladder volume changes by 2 or 3%. And so if you have a 15-minute treatment, that kind of bladder filling motion can also impact your treatment within the fraction itself. So, but you can see these again with ultrasound, if you have an ultrasound in the room, or in cone beam. If you use a cone beam CT, you can see the bladder very clearly, and determine if it's gotten too big or if it's not big enough yet, relative to your treatment plan. Okay, so those are some of the passive ways we deal with motion. It's not too sophisticated as some of these active motion managements, but we do every single one of those in our clinic. And the reason for that is if we can at least take care of the more simplistic passive methods of reducing motion, then the little bit we have left, we can usually deal with either with margins or with some form of image guidance. So I would heavily suggest, if some of these things you haven't practiced in your clinic, these are very, very useful for reducing motion. Now, the active motion mitigation is very important for respiratory motion. And that's kind of the motion we're all very familiar with that we see in a lot of these GI and these thoracic treatments. So for simulation, for example, here we have a patient being simmed for a thoracic treatment. We have this SBRT vac lock bag that I had mentioned earlier. We have other immobilization devices in here. For example, there's a wing board in here. There's a T-bar that we have the patients hold on to give them a very reproducible setup. We have a knee wedge to go under their knees. That is both for reproducibility, but as well as for patient comfort. We'll talk about this here in a second, but we have a bellows on here to monitor the respiration rate. And so for these patients that you anticipate that you'll have a lot of respiratory motion with, again, your thoracic patients and your GI patients, oftentimes whenever they come for simulation, we'll administer a 4D CT, where the fourth dimension, the 4D part of that, is the respiratory phase. So we get 3 spatial dimensions with our CT, our normal CT, but by performing a 4D CT and basically imaging the same anatomy 10 times, you can now separate out different phases of motion. So for example, we give a CT, or we hook up these Phillips bellows. So these are the things I showed on this previous slide across the waist. You can measure the amount of pressure that's exerted whenever a patient takes in a breath and when they're breathing normally. And you get this respiratory trace here on the right. Well, if you acquire a CT with a low enough pitch, basically where you're imaging the same anatomy up to 10 times, you can now separate a single slice of a CT into these bins. And typically we use 10 bins. And each one of these bins is associated with a phase in this respiration. You can also bin according to the amplitude, basically how high the respiratory, or how the chest is during the respiration. But for MD Anderson, at MD Anderson, for our purposes, we actually bin by phase. So basically, are they in end inspiration, or are they at near end expiration, essentially? So at 0%, you have end inspiration. At 50%, you have near end expiration. That's whenever they release all their breath and they're at the very low end of their respiratory cycle. And by bending this, you now can form these images. This is a single coronal slice that we've reformatted, and you can image the entire range of motion from these tumors. So this is one slice that we've essentially bent into 10 different phases of respiratory motion. So it's like one slice getting 10 CTs over and over and over again as the patient moves on the table. And so this is really useful because now you can measure this motion. And as I don't know if you saw on the previous slide, that task group TG76, they recommend that anytime your motion, your peak motion is greater than 5 millimeters, you should probably do a breath hold for your planning and for your treatment. At MD Anderson, we don't. We do 10 millimeters. That's based off the experiences of our physicians and the comfort that they have administering a margin associated with 10 millimeters of motion. But I do know clinics that do stick with 5 millimeters as is recommended by the task group. But again, at MD Anderson, we'll take this 4D, we'll pull it up on the computer, and we'll say, okay, is this tumor moving more than 10 millimeters or not? If so, then we'll have to do a breath hold. But if not, we can continue with our free breathing techniques for planning and for treatment. And this is an example of kind of what we see during planning. So if we have a tumor that's moving a certain distance, if you take your bend CT, your 4D CT, and you calculate what the average position of the tumor is, you get this middle image. You get this kind of this darker area, or this think of this as the proportion of time the tumor spends in each phase. And you'll see that towards the end, you have a little bit longer of a period where it slows down and decelerates, starts to accelerate back. I think this gives you an idea of over time where the tumor is during this free breathing respiratory cycle. If you, instead of taking the average, you take the maximum intensity projection, which basically says anywhere the tumor is, color it white; anywhere the tumor is not, color it black. You now get an idea of any potential area the tumor is at any point of time during the respiratory cycle. And so what our doctors will do is we'll create, at simulation, we'll create an average and we'll create a maximum intensity projection. The doctors will usually look at the maximum intensity projection when they're trying to contour. They can look at individual phases, but ultimately when they're trying to determine the margins, the ITV essentially, they'll look at this maximum intensity projection. But then they transfer those contours from that MIP image onto the average image, because that average image is technically what is more realistic during treatment. Your MIP is just anywhere your tumor could be. Your average is, where's your tumor probabilistically at any point in time. And I think this is exactly what I just said, so we don't have to spend too much time on the slide. But yeah, so we contour on our MIPS for these free breathing scans, and we plan on our average. We transfer the contours from the MIP to the average, and then we actually plan on those average scans. This is kind of a look at what the different contours will look like based off which scan you're looking at. So if you have a free breathing scan, you're capturing the tumor at some random phase within its respiratory motion. So that's one particular, phase, if you will. If you look at the average, you get this kind of spread out area of the tumor. You can actually see this intensity distribution that's a little higher towards the each end of the motion. And then if you look at your MIP, this is kind of what you're looking at. So this is just the spread of all potential areas that the tumor occupied. And so they'll draw these margins based off this MIP, and then again transfer to the average for their planning. This is kind of the error you can get when you don't. So for example, if you look at one phase, the end inspiration phase, for example, you contour your tumor on here, and then you look at the other phase, your end expiration phase, you can see that the contour is significantly different, which is what we would expect. And then if you were to look at all the phases on the MIP, this is kind of what you see. And this demonstrates that you can usually get away with contouring at least the two extremes in terms of incorporating the majority of the motion. But again, our doctors will look at each phase and actually determine, okay, where's the tumor on this particular phase of the respiratory motion. So say we are at simulation and you need, you notice that there's over 10 millimeters of motion, at least at our clinic, or you're very close to the diaphragm or a sensitive organ that you're trying to avoid. In those cases, we'll actually implement what's called breath hold. So breath hold is where we will ask the patient to take a comfortably deep breath in or out. You can do both kinds. And we'll talk about that in a bit as well. But you're trying to freeze the motion during one of those particular respiratory phases. And we've noticed that we don't want the patients to take in a huge breath. Obviously, the bigger the breath you take in, the more your lung volume expands, the more you separate different organs within your body. But we've noticed that when we ask the patients to take as big of a breath in as they can, it's not as reproducible. And you actually will get motion on your breath hold scans from breath hold to breath hold. So we ask them to take a comfortable breath in where they can hold it for 15 or so seconds. And during that time, we'll acquire a CT during the simulation and we'll plan on those breath holds. And then during treatment, we'll also ask them to take the same breath hold and treat during that breath hold. And you can see the difference here between a free breathing scan on the left for a large amount of motion, and then on the right when we ask them to take a breath hold. So the most important thing that you can do with these breath holds is be consistent. So during simulation, we'll take 4 or 5 different breath hold CTs, and we'll ensure that from breath hold to breath hold, the patient's consistent, that the anatomy doesn't change significantly from one to the next. Well, I guess I can talk about this now too. During treatment, we also we double check the breath holds as well. And the way we do this is when we acquire a cone beam or a planar X-ray during treatment, we'll ask the patient to take a breath in, and we'll first align our image of the day to our DRR, our digital reconstructive radiograph, and we'll align the bones together. Typically, the vertebral body is what we use for our bony alignment. And then we'll find the tumor and we'll align the tumor. And the idea is that if your image of the day breath hold is consistent with your simulation breath hold and you're planning what you planned on, then the difference, that shift and that difference will be minimal between your bony alignment and your GTV alignment. Not the individual alignments, but if you aligned a bone and you get a shift, and then you aligned your GTV, your tumor, and you get a shift, that difference in shift should be very minimal if you're having a consistent breath hold. We typically allow for 5 millimeters. If it's above 5, we'll acquire another cone beam CT or another planar X-ray. And if we're still off, then there's a chance we might actually have to resim, because that means that our breath hold is no longer consistent to what we had planned on for the simulation image. If we're consistent, if we're above 5 millimeters, but we're consistently around the same value, then it's physician dependent, but usually they're comfortable for treating regardless. So if your difference between your bony alignment and your tumor alignment was about 7 millimeters, and you did that 2 or 3 times, then at that point, at least you know it's a consistent breath hold and you feel a little more confident when you're treating. So if we do a breath hold, we use the Phillips bellows to look at the respiration cycle, but we actually we define our breath hold using the Varian RPM, the real-time position management system. And what that involves is an infrared block that we place on the stomach of the patient and an infrared camera. And you're actually able to track the motion of that infrared block in real time. And one really cool thing that they've developed for it a while back was the ability to feed this back to the patient so they could also see their breath hold. That's the biofeedback part of this. But what we do is we gate now. And interestingly enough, when we bend our simulation CT, we bend it based on phase, but here we're actually gating based off amplitude. So when that box gets to a certain level, we'll gate the beam. So this is where what we use to define our breath hold during the simulation. So we'll put these goggles on the patients, we'll put the infrared block on, and we'll ask the patients to take a breath. And once it gets to that yellow bar, which represents the box, the level of infrared box, once this gets into the area, the acceptable tolerance, essentially, we'll ask the patient to hold their breath there, and we'll take a CT there, and that becomes our breath hold CT. Now, when they go to the treatment, we replicate this setup exactly as we did during simulation. So we'll put the box in the exact same place. We'll actually have the therapist draw where on the patient that box is as every day. Because if you move it, now you have a different amount of motion associated with the same amount of breath hold. So you always want to put the box in the same location during treatment. And we'll have the patients go put the goggles on. We'll practice with them before we start treating. And then once we start treating, this becomes our gating device. So the whenever that yellow box goes into the blue tolerance region, meaning that they have an acceptable breath hold, we'll turn beam on. And then the beam automatically turns off or gates whenever they lose that breath hold. So we only treat using this under breath hold. There is real-time gating that some clinics do. So instead of asking the patients to take a breath and hold and having this then gate that section, some clinics will actually define a region that's acceptable to gate in, and they'll have the patients free breathe. They'll just have them breathe normally, usually pretty slowly. And it means that they don't have to have a breath hold, but the treatments take longer because now you're only gating whenever the respiratory phase is in the right area. Um, but it makes it technically a little easier because you don't have to coach the patient into holding their breath at the exact same spot every single time. We don't do that here. We either treat under free breathing without gating, or we treat breath hold gated. Those are the two that we do here at MD Anderson. So again, we kind of talked about this. The components are um, you have this infrared block that we put on the patient here. Here's this camera that we attach to the table of the simulator. And this is kind of the respiratory cycle that we get. And here you can kind of see this is probably where the patient is either asked to hold their breath or they coughed or something. And there's this predictive filter that they use that basically can help make the treatment a little more efficient. It determines, okay, is a patient about to lose a breath hold, or can we keep the beam on? So it helps with the timing of the gating, if anything. There is a bit of really interesting development when this first came out. The first thing was getting this biofeedback incorporated into this device. So they actually had either VR goggles, which are used now, or this LCD display with a mirror here. And this helped the patient see exactly where their breath hold was, if they were taking too deep of a breath or not a big enough breath. And this helped to make these treatments a lot more efficient because now the patient didn't have to guess, or the therapist didn't have to verbally coach the patients, okay, take a bigger breath in or let some air out. It allowed the patient to participate in their treatment. So that was a really useful development for this device. Also, they developed within the gating software itself a timer, and it turned the beam on only after a second they've gotten into the tolerance region of the breath hold. And that's important because there is a delay with turning the beam on and turning the beam off. And so if a patient coughs, or if they take a deep breath, but then they realize they need more time to breathe, the beam won't actually turn on unless you're in the appropriate window for at least 1 second. So they noticed that this was actually really useful. Yeah, it extended the treatment a little bit longer, but it was really useful for eliminating any incidental radiation when the breath hold wasn't really a true breath hold, when it was because it was a cough or something else. So again, there's different modes of operation. I won't get into this too much, but there is a phase-based gating. So you only gate when you're in a particular phase of the respiratory cycle. And I believe that's what's used more in your free breathing gating techniques that we don't do here, but other places do. But then there's amplitude-based gating, which is what we do. Basically, whenever your infrared box gets into a particular area, that's when you actually start turning the beam on or turning the beam off, essentially. Each come with their benefits and detriments. The phase-based gating is a little susceptible to irregular breathing patterns. And oftentimes you'll see these patients do have irregular breathing patterns, especially when their primary disease is in the lung. Amplitude, you have to be careful because you have some baseline drift. Whenever a patient gets on the table, they're a little excited, they could be stressed, their breathing rate's higher, their breaths are deeper. So typically what we'll do is we'll actually have the patients lie on the table for about a couple of minutes before we do anything. Well, we can set them up, but before we turn any gating devices on, before we turn on our RPM, and that helps them calm down and has their breaths become a little more reproducible. And so it prevents this drift, basically this amplitude drift that you often see whenever you're gating based off the amplitude of the RPM box. There's deep inspiration breath holds and there's deep expiration breath holds. This is kind of an interesting topic because I've seen plenty of data that says that you get more reproducible breath holds whenever you're doing deep expiration breath holds. But I think it's more difficult for the patient because you're asking them to basically take a breath in and then expel as much air as they can and hold that. And I think that psychologically is difficult for a patient rather than taking a deep breath in and having them hold their breath as you naturally would. And that's what you kind of see in this deep inspiration breath hold. I think we used to do more expiration breath hold based treatments here at MD Anderson. And we do sometimes. If we get bad anatomy during an inspiration breath hold, we can go to an expiration breath hold where they're releasing breath. But I think our default is that we ask patients to take a comfortable breath in, which is what is a deep inspiration breath hold. And a big benefit for this as well is when you take a breath in, you're actually expanding your lung volume. And so your mean dose to your lungs actually decreases whenever you're taking a breath in versus when you're expirating or pushing all the air out of your lungs. And again, also, it can create a little more separation between whatever target you're looking at and either the heart or the spinal cord. That you actually would minimize that distance when you're doing expiration breath holds. So there's benefits and detriments to both of these as well. But I think the benefits of the deep inspiration breath hold outweigh the slight benefit you get of more consistent breath hold with the expiration breath hold. So just kind of as an overview of what we do with our workflow at MD Anderson. So we monitor the respiratory rate using the Phillips bellows, that waistband, during the free breathing scan. And based off this respiratory rate, we determine the pitch of our 4D CT, that pitch being how fast does the table move when the beam is on. For slower respiratory rates, you have to slow the table down. Otherwise, you risk missing some of those bends throughout the 4D CT. The patient is a little more active with their breathing. You don't need to spend as much time at each slice because you can acquire more bends of your phase, more phases at a more rapid rate. We bin this data into our 10 phases respiratory motion, and then we measure the maximum distance using the 0% phase and the 50% phase. Our 10 millimeter cutoff is what we use, but again, you can use 5. If we determine that a breath hold is needed, then we'll set up this variant RPM system where we have the goggles in the box. We'll ask them to take a couple breaths in and set the reference settings for the RPM. And then they reproduce this breath hold a few times before we actually acquire the CTs. We document, again, where the RPM is and the settings that we used because that's exactly what we use during treatment. So during treatment, again, put them in the exact same position as we had during simulation. Only when the patient is fully aligned to lasers do we start recording the RPM. And the reasoning for this is our camera in the treatment room is actually on the ceiling rather than on the table. And so if you start recording while the patient had just got on the table before they're aligned to their final isocenter position, your relative angle at which your recording changes, and if you just do basic geometry, the distance that you're measuring also changes as a result. So we wait until the patient is fully aligned to lasers before we actually start recording because of that. We use the same tolerance window as I mentioned. We ask the patient to take in a comfortably deep breath, just as they did during sim, and we perform our imaging, cone beam or our planar imaging, either with the KV or the MV. And then we do SBRT. Again, we measure this difference in bone alignment and GTV alignment or tumor alignment. And as long as this difference is within about 5 millimeters, then we're okay to treat. We then treat through a series of breath holds where we're gating the beam whenever the respiratory rate or the breath dips below where it needs to be. And and then we repeat over and over again. All right, so I'm getting close to the end. There's a few papers that I just wanted to briefly show up here because this is the main type of motion management we do at our clinic. There were a few other ones that I briefly wanted to mention before I opened it up for questions. This is just data showing that your gated treatment has obviously a much better target alignment than your non-gated treatment, which is pretty obvious. This compared expiration breath hold to reproduce the same setup over and over again. And again, this looked at if you had if you did a breath hold based off your RPM system, where you're looking at abdominal motion, does that actually correlate with internal tumor motion? And a study we did here back in 2007 actually demonstrated that yes, in fact, especially in the area that the dimension you're interested in looking at, it is a good surrogate for the most part. Other things that we use here at our institution, which are pretty common, are surface guidance radiation therapy, surface guided radiation therapy. So here, the Vision RT is the more prominent one that we use here, but there are other companies that do this. They shine a light, an infrared light, at the patient, and there's a camera that records a speckle pattern. And as the patient moves, that speckle pattern changes, and you can determine whether the patient needs to move in a certain direction based off the speckle pattern. This is nice because there's no box you have to put on. You just have the patient lay just as they would during sim, and you capture during a dry run that position that they need to be in. It's real time, and there's no radiation involved with it. So this is a very common way to treat, and especially whenever you have biofeedback through goggles, for example, you can get a very reproducible setup, between breath holds or between fractions. As I said, there's alternative surface imaging. So again, Vision RT or Align RT are the two big ones, or the main company that we use. But there are a few other ones like CRAD or Identify that Varian uses that is also useful for surface guided radiotherapy. It's a really hot field right now. There's a recent task group that got released last year talking about how you actually utilize these in the clinic. So if this is something you're interested in, I highly recommend this task group report. You also have ExactTrack, and this is the last one I'll talk about. This ExactTrack Dynamic is the more upgraded version, but this is something that can implement surface guidance just as we talked about. But the overall ExactTrack system is actually this pair of orthogonal X-rays. So you have two X-ray sources here at the bottom, adjacent to your LINAC, and then you have X-ray panels. And what you can do is you can take these X-rays in a very quick fashion because they're not attached to the linear accelerator. You don't have to wait for your onboard imaging to move to the right position. It's very quick, and it's very useful for if you have patients with fiducial markers in them. So for example, we have prostate patients that we often will put in through fiducials. And with three fiducials and this ExactTrack, you can actually localize exactly where the prostate is and how it relates to where it was during simulation. And so during long treatments, again, because of bladder filling and a few other things, we'll actually take ExactTrack X-rays multiple times throughout treatment. So this is a really popular method for also monitoring motion. You don't get the real time as you do with surface guidance, but it gives you a really nice quick snapshot of internal anatomy that you don't get with surface guidance. And as I said, this new dynamic system actually does have a surface guiding component to it. And you can use this to also gate the beam. In all of our head, neck, and CNS treatments, we actually use this dynamic system. And so we'll put the patients in their mask, we'll lay them down, and only whenever they're in the exact same spot, according to ExactTrack, will we actually start treating. I feel like at this point, I should probably stop just in case anyone has any questions. I have a few other things that we could talk about. My area of work, the MR-Linac, is like the latest and greatest in motion management. But I feel like a lot of people are familiar with how it works. I mean, if you know how an MRI works, you know how a linear accelerator works, you know how an MR-Linac works. The benefits are tremendous because you can actually image internal motion in real time and without radiation. So you combine your X-ray imaging that you get with your exact track with your real-time imaging of the either the RPM system or your Vision RT. But the problem is it's very expensive. Like these systems are ungodly expensive right now. And you even have companies that are struggling to stay afloat because they are so expensive to make and they can't sell them fast enough. So MR Linux still has a little bit of way to go, but it's a very hot area of research. Um, and there's a few other technical challenges associated with it, but that's going to be the latest and greatest in motion management. It's just not the most widespread applicable technology for motion management. The ones that we talked about today, these are ones that I feel like are very accessible and ones that can be easily implemented without too much technical prowess or experience to get it up and running. So yeah, so I'll stop here. Thank you for your time today. Sorry I rambled for 55 minutes, but I'm happy to take any questions that anyone may have.
Yeah, thank you so much for for the lecture. Please, if you have any question, you can raise your hand and then unmute yourself. And you can also type in the chat box for your questions as well.